Good afternoon and welcome you all to our yet another live show discussing the state of Indian healthcare during COVID-19 pandemic. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, a not-for-profit social impact initiative to promote health for all. The coronavirus pandemic has brought to the fore several contradictions of our society. While we saw most of us locking ourselves to the comfort of our homes, we have also seen lakhs of people swarming the road in lack of a place to stay put during these lockdowns or to reach a place which they call as their home. We are seeing heartwarming praise and support to our often ignored and criticized healthcare workforce, but we are also seeing our doctors and nurses being chased away from their homes as their neighbor fear infection from them. While the existential uncertainties have made us all realize the importance of our families and loved ones like never before, it has also forced many away from their nears and dears to fight this fearsome disease in isolation. And most unfortunately, it has also led many dying in these quarantines with no one from their families by their side. It's really difficult to imagine the mental suffering of such people who lost their lives in isolation or those who lost someone like this. And it is equally grim to see the trauma of many those who were neglected, marginalized in our society, and this pandemic has just further driven them to brink. But should the brutal contagiousness of this virus be allowed to take over what is human? This is the question we will try to seek an answer for today. We'll try to seek an answer about what it takes for us as a society or our healthcare system to ensure that all those in suffering, in pain, get all that solaces them, comforts them, helps them live easily and die naturally when it's inevitable. In health parlance, it's called palliative care. The WHO defines it as a care that helps patients with life-threatening diseases and their families in prevention and relief of suffering, while providing a compassionate physical, psychological, and spiritual support. The World Health Assembly calls it an ethical responsibility of all health systems and demands palliative care to be integrated at all levels of healthcare, from primary to tertiary. And in its recently held annual meeting, committed governments to ensure delivery of palliative care alongside safe testing and treatment of COVID-19. But what is this palliative care mean for 1/6 of humanity that lives in India? And how much we as society care for palliative care? To understand this, we have today with us some of the most admired public health experts and palliative care ambassadors. Let me introduce our esteemed panelists today. We have with us Professor K. Srinath Reddy, President of Public Health Foundation of India, an internationally acclaimed public health visionary. Dr. Reddy has served many WHO experts panels and has been the president of World Heart Federation. He is also an adjunct professor of epidemiology at Harvard. Professor Rajinder K. Dhamija, head of neurology, Lady Hardinge Medical College and SSK Hospitals in New Delhi. We have with us Dr. Rajni Surinder Bhatt, pulmonologist, Apollo Specialty Hospital, Bangalore, and Dr. M.R. Rajgopal, chairman of Pallium India and director of Trivandrum Institute of Palliative Sciences. Our first session is going to focus on the need of palliative care in sustainably managing COVID-19 infected. So let me begin this session today with Dr. Srinath Reddy. Dr. Reddy, you are a veteran of India's public health, and you have seen over the decades how Indian public health system has responded and supported healthcare. What is the response you are seeing from India's healthcare system to this pandemic so far? And is palliative care being included in this response? Dr.
Well,
Reddy.
when we look at palliative care in the context of COVID-19, we have to ask ourselves, how is palliative care actually being provided to those who are infected with COVID-19 and hospitalized? Secondly, how to care provided to all others with chronic conditions who require palliative care as part of their management and support. In both of these triple deficiencies, firstly, as far as COVID-19 is concerned, we are seeing that palliative care is not being provided to the extent it needs to be because of a variety of reasons. Firstly, some of the hospitals, which are actually the assigned hospitals for admission, are getting overcrowded and they're getting a fair amount of caseload, which does not give the healthcare providers the kind of time they can devote for palliative care by themselves. Secondly, the infective nature and the isolation of these patients means that the family members cannot really participate in providing the kind of emotional and social support that's required. Then even from the point of view of the healthcare providers, we are seeing that the clinical course is one of sudden deterioration when the cytokine storm comes in. So by the time a patient is supposed to be now seen as somebody drifting from a fairly stable condition to a very critical condition, the time span is very little. And therefore, the plan for palliative care doesn't often become operational, even because of that feature. Last, of the fear among the healthcare providers that they might, and all the case reports of doctors and nurses getting infected, some of them critically so, is also a fear factor that affects. But the important element is how much should we really continue to distance the patients from the family support and they require in terms of the kind of social and emotional support they require at that time. And even in a crowded environment, should not the healthcare providers be providing even some element of emotional support and palliative care? I think the answer to both those questions is absolutely yes. And particularly from the point of view of ensuring that at least some kind of conversation is possible between the family members who are already admitted in the intensive care or in the isolation wards is absolutely important. Whether it is a recorded telephonic message or an actual telephone call that can be done, or whether it can be other forms of communication. If people on Earth can speak to astronauts in space, I can't see why people outside a glass window cannot be able to reach out to the people in intensive care. So we ought to be able to actually use technology, certainly, but all other means of effective emotional and social support being provided to people. But at the same time, palliative care in all forms needs to be practiced as much as possible by every single healthcare provider as well. And second element, of course, is that all other conditions which are now falling by the wayside and getting neglected, chronic conditions where palliative care has been mandated and has been practiced, they no longer should be neglected. We cannot afford to ignore that aspect of it, even if we are rushed by the public health emergency of COVID-19.
You are making a very important point, Dr. Reddy. You're mentioning that, apart from the crowded hospitals, and that might have led a situation when the palliative care might have got sidelined. But the important aspect, which is important for a healthcare enthusiast like me, you are saying that even a phone call or a recorded video message with the family, we never thought about that. This is also part of some care. We always thought that care means something, providing medications, providing healthcare support, making a patient talk to their family or a family to talk to their patient. Is it also part of a care? we haven't seen that much happening, or we never got sensitized for that. Do you think that our healthcare professionals who are managing COVID-19 and other diseases also at all level of healthcare system have been sensitized for this, or have been especially trained for something like this, that for a patient who may be suffering in isolation, even a call with their family might be a big relief?
Unfortunately not. The nature of our training and the nature of our practice, even in the clinical settings, has not really provided that kind of empathetic attitude or even a sensitivity towards the need for palliative care. Firstly, it has been said a couple of centuries ago that the duty of a physician is to cure some, relieve most, but to comfort all. Therefore, the care, concern, compassion, courtesy, and communication, which is an important element, is neglected in the training of healthcare professionals. And frequently, there is an attitudinal issue. We are sort of told that you should not get emotionally engaged with the patient, because then you will pay a price yourself. You have to have that sense of detachment. But that's not really true. I mean, if that were entirely true, I'm not saying that we should get emotionally attached to the extent that we feel shattered. But unless you have that sense of empathy, you don't carry conviction when you try to comfort a patient. And if that empathy were so destructive to the care provider, then Mother Teresa wouldn't have lasted so long. The second element, of course, is that there is also in medical training a sense that we must win this battle, and every death is seen as a defeat, and we turn our face away from defeat. The fact that there is actually a transition to death, where also we can play a supportive role, is something that is not really adequately taught in the clinical care settings. And that is something that must be taught right from the student days. It is absolutely critical. In fact, the first three letters of palliative care are PAL, P-A-L, which means a friend. So a doctor has to be a friend as well. A nurse has to be a friend as well. So that is the element that needs to be brought in very clearly into our training program, both in terms of the classroom training of what the doctor's attitudes and skills must be, but particularly in the practical setting where they should have role models who can display that level of empathy and support that makes palliative care an acceptable element of all doctor-patient interactions, particularly those who are having terminal illness.
Thank you so much, Dr. Reddy. But just I would like to request you to repeat that statement for the purpose of our public, that how the healthcare system should behave. Those lines that cure some, relieve many, and comfort all.
Yes, because that is the important element. We may not be able to cure all, and we see that very often, even despite all the scientific advances, we can't cure all. We must try and provide relief to as many as possible, particularly when they're in terrible pain or suffering. And that's also part of palliative care. But comforting all as much as possible with a sympathetic attitude, that we are, in a sense, identifying ourselves with the patient and giving that sense of support is an important element. And the final passage, when it comes, the patient must go with the comfort that he has, the love and affection of his family members, but also a doctor and a nurse who have done their best and have been their friend, the patient's friend at the time of parting.
Thank you. So let me just turn to Dr. Dhamija, somebody who is, fighting this so-called war. And I think, you also have highlighted that this whole battle narrative is also maybe taking some toll on how we are dealing with COVID-19 and its, victims. Dr. Dhamija, when Dr. Reddy says that, cure some, relieve many, and comfort all, how much you are able to do, or the healthcare professionals like you are able to do in the real life settings of somewhere like Lady Harding's hospital with the COVID-19 patients? Is it being practiced?
So just to continue with what Professor Reddy said, that even the WHO says that the most fundamental goal is to relieve human suffering. So that's the idea of having a palliative care. And if we take in context of COVID-19, so WHO says it's a humanitarian crisis. So it's one of the humanitarian crises, the COVID-19 epidemic. And this is epidemic which is severe acute crisis of unknown duration. We don't know how long will it last. We keep on coming with mathematical models. This will peak this time, this will peak that time. These are the numbers, these are the number of people who are recovering, and this is the doubling time. You read every day, you read in the newspapers with new numbers. But if you take it on the context of physicians as well as the patients, so this has caused a massive physical, psychological, and social suffering to the massive number of people. I mean, huge number of people. We don't know how many people will still be infected in the coming months, and how many people would be, dying in these difficult times. So if we take it on the ground level, so what we need to do is the 5 principles of WHO, which is really relevant in these times. They say that the WHO has said that. So most fundamental, as I said, is relieving the human suffering. And they also say that we need to respond, and the response should include palliative care and symptom control right in the beginning. So it's just not the saving lives. Saving lives is as important as it should be, medically speaking or ethically speaking. But to comfort these patients is equally important. It should be integrated with the life-saving missions of the cure mission, or the curing aspect of the treatment. So what we see today is we are focused on prevention as well as curative type part of this whole approach to the epidemic. So we are not talking about the holistic approach, the integrated approach of palliative care in terms of symptoms control, in terms of at the level of triage, or at the level of ICU, or at the level of different care pathway. So what we need to do in our experience, what we have done, is to start talking about palliative care, or talking about palliative care is not just the end of the life. It starts right from the beginning. So like the Professor Rajgopal would enlighten us better, the way the Kerala has produced a pyramidal model of triage, red, blue, and green. So it has all the 3 components of severely critical patients not likely to survive, or likely to survive, or does not need immediate treatment but will require at some stage. So all 3 stages we need to involve, or at least integrate palliative care right at the trial. And then once you integrate this, whether you do it at a OPD level or you do it at the ward level, so once you integrate, the whole system will activate. So that's what we have been trying to do at our hospital, which is a COVID dedicated center. So we have been sensitizing the COVID physicians, or the frontline workers who are dealing COVID patients every day in the wards, and we have been sensitized to be part of this whole holistic approach to the patients involving the palliative care. So that's one thing. And we have not only sensitized them, we have also explained them the role of palliative care in these circumstances, and we need to respond very quickly and flexibly. We also need to develop protocols, which we have tried to do it at some stages by training the physicians, or training the non-palliative care specialists in Delhi at least. And we are also being involved in considering the redeploying our volunteers at a different levels for the virtual home visits or the home visits. And we have also been using technology for the telemedicine, and we are finding challenges as well in this technology in day-to-day patient care.
Okay, so thank you so much, doctor, for highlighting that what all is being done at your level, or at the hospital where you are. It's a important public health institution. Let me just turn to Dr. Rajni. She is associated with the private healthcare system. Dr. Rajni, how palliative care is being seen at private healthcare side of it? We have seen some of the cases recently where patients have not got that kind of responsiveness even at the emergency rooms of these hospitals, and many of them are being kind of turned back from the hospital gates. We are not naming any hospital, but do you think that in an environment of fear, where from public to healthcare provider, everyone is living in some kind of fear, how palliative care is being integrated in healthcare system being provided by public health private players?
Well, Sinara, I'm glad that you said that it's not it's not a specific thing about one hospital or another, and I can only speak for my experience in the private health sector. And the hospitals that I have worked in, we've tried to have an integrated palliative care model, whether it's integrating the palliative care approach from the emergency room to the patient's care in the wards, to the ICU, or to procedures. And I think that comes from a culture of the institution. So in our institution, we have a culture of approaching the patient's goals of care. And, the more you do it, it's like practicing any procedure in medicine. We talk about the fact that people are uncomfortable with conversations. These are very difficult conversations. Apollo hospitals, Apollo specialty hospitals in Bangalore, where I worked earlier, is not a designated COVID hospital at present, but we had systems in place so that communication is streamlined, goals of care are discussed with patients. Trust is a very important thing. So especially when you're talking about a disease like COVID, where prognosis is something that can be, when you look at a patient who's severely ill, who might require mechanical ventilation, these are difficult conversations, very delicate conversations to be had with the family so that they can make appropriate choices about whether they want life-sustaining treatments or not. We've had a lot of progress in the recent months and years because of pioneers in the field like Dr. Rajgopal, and we are slowly seeing a shift in healthcare overall in the entire environment in India towards humane and ethical healthcare, which is not afraid of the law and understands that doctors work within their ethical construct with the support of professional societies and guidelines. So I don't think the private health sector as a blanket is not treating patients appropriately in terms of palliative care. Wherever institutional leaders are there, you will see very good incorporation of palliative care. And I hope that the entire system has institutional leaders coming up so that we bring in a culture of palliative care integrated right from emergency to all specialties to ICUs and procedures. And education is the way forward. We need people who are passionate about it in every field to take the field forward.
Wonderful. So that means that private healthcare sector is also taking palliative care with all seriousness. Dr. Rajgopal, you heard a public health veteran saying that there has in Indian public health system also palliative care is moving forward. It is being kind of accepted and integrated. Public health care professionals saying that they are using palliative care at every level of their care system, and a private healthcare professional saying that yes, it is being considered and taken in full sincerity. You have been always working towards bringing palliative care to the notice of the people in India, and you have done wonderful work in Kerala. What is your take after hearing them? Have we really moved forward, or there is a large or long way to go?
Thank you, Kamal. So I agree with everything that has been said. And I agree that we are moving forward. We are moving forward, unfortunately, at a snail's pace. That's the truth. I mean, we used to say maybe 15 years back that less than 1% of India's population have access to palliative care at some point of their life, which may be in the last few hours. And today, we would say that it's about 2%. And that clearly is progress, but too slow progress. And I really hope that we are on a steep part of that curve of growth now. But the fact that Dr. Dhamija and Dr. Rajani are talking about this from that kind of institutions fills me with hope. If you are specifically asking about the COVID situation, no state, including Kerala, has included palliative care in the strategy yet. This is definitely a need. But Kamal, I don't know if you want me to go into that at this stage or later.
No, obviously. So I was definitely talking from the larger point of view, not specifically on COVID-19. COVID-19 is a one extraordinary situation which we all are facing. See, what I believe is that the day-to-day healthcare system is the healthcare system for pandemics. You don't need to put together a new healthcare system to deal with a pandemic. It is your day-to-day healthcare system which should be resilient enough to respond to a situation like COVID. And from that point of view, I am asking if it has become our, the nature of our, healthcare services, where the palliative care is integrated. You need not to, have a specific attention to include it when it comes, pandemic. It will automatically come into that. So that's a different thing that you are saying that the states have not included that in the strategy. So I'll go back to then Dr. Reddy. Dr. Reddy, WHO says that, and it's good that now our health minister is heading that decision-making body. And in the recent meeting, they mandated to bring in palliative care in the COVID response, along with safe testing, along with safe treatment. How do you see it now? Is there a larger chances of government policymakers getting involved in making palliative care more institutional, especially during this COVID-19? It is maybe a great opportunity given to us, where we have realized the need of palliative care now like never before. And from here onwards, the complaint which Dr. Rajgopal is making about the snail pace of the growth is going to be completely changed scenario. Dr. Reddy.
Well, I think we will definitely see a change, not necessarily because of the COVID situation, bringing about sudden awareness of the need for palliative care, but because we are going to be seeing a lot more expansion of our health workforce, because there's been a clear realization that we are very short of health workers in all categories, and that a health system that is inadequate in terms of health infrastructure, but more so in terms of health workforce, cannot suddenly build a surge capacity when challenged with a public health emergency. So we are going to see a lot more emphasis on producing more non-physician healthcare providers, technicians, basic doctors, and of course specialist doctors, but a lot of nurses and others as well, including nurse practitioners. So there's a great opportunity now as we are reconfiguring our educational system, both in terms of scale and skills, to introduce palliative care as a very important element throughout the education. And I think that way we can actually utilize this opportunity. In terms of actual sensitivity of policymakers, I'm not sure immediately this emergency is going to make much of a difference, as much as it should. But the very fact that we are now re-looking at our health system overall gives us an opening that we should utilize very well. And that is where we should talk to the Medical Council of India's interim governing board, as well as the newly formed Medical Commission of India, National Medical Commission, to the nursing councils and others, and saying, okay, how do we actually get more of palliative care into the overall curriculum and training program, and how do we instill these values and skills at every level of our training?
That's a good long-term solution, Dr. Reddy, if it is included and given due importance within the medical education system. But for this immediate requirement of making palliative care and at least part of it available for the people who are in real suffering, do you think that there can be some quick way to impart some kind of training, some kind of awareness, and sensitize our healthcare workers on some immediate quick response manner. Like Dr. Dhamija said, that they have sensitized the whole workforce in their COVID hospital. Do you think that it can also be done?
Of course, those who are already in position must be trained and sensitized. There is no doubt about it. And secondly, we must also recognize that every single healthcare provider at some point in their life have seen one of their family members actually be admitted with a serious illness and face the situation. So it is not as though they are not aware of the need for it, except they've not personalized it when they actually deal with other patients or other families. So it is that awareness that must be brought to them, that if you were in this position or if your family member was in this position, how would you like them to be treated? And that awareness and sensitivity must be brought in throughout the training. And if we are spending so much time on webinars all over the place during this period, we could actually do a lot more in terms of bringing in some of this awareness as well, both on site as well as even otherwise, using all our technology to bring in this awareness and instill some skills and sensitivity. So we ought to do that even with the people who are already in position. There's no doubt about it.
I think webinars also help in spreading awareness a little bit, making more people sensitize about what palliative care is all about. And that, that from there, at least they can start practicing it more. Dr. Rajgopal, Dr. Reddy is saying that, yes, it is being embedded in the medical system, education system. There can be more things done. And there is also an opportunity for all of us to bring this awareness more to the public or who need it, to the families, and also to the healthcare professionals. What solution you have, which you might have utilized in Kerala, and give some kind of hope for the entire country, and we can replicate it?
There are two parts to my answer. One, as Dr. Reddy said, we can, over the long term, have a sizable part of the medical community who are sensitized to palliative care. If from 2019, most elements of palliative care are officially in the MBBS curriculum. But who will teach it? Of the 525 medical colleges in the country, maybe about 30 would have some palliative care established there. For the others, we are conceiving training programs for the faculty to teach medical students. That's a process that will take time, but that is the only way we can move forward. So totally agree with Dr. Srinath Reddy there. Secondly, the second part, now, if I am getting COVID-19 next week, I need it now. Okay, the best example that I can give is from Uttarakhand from last week. Look, for the last 2 months, working with a large group of palliative care doctors, they have called themselves Palli-COVID Kerala. We created electronic guidelines, e-guidelines, and echo-based courses. Last week, from Uttarakhand, by the decision of the National Health Mission of Uttarakhand, 131 healthcare providers underwent a 1-week course. Every day, they would spend 75 minutes, 3 p.m. to 4:15 p.m. with us from Monday to Saturday. And that course was completed by these people, including about 35 doctors. Now, what would it help? How would it help the patient and them? They are not going to learn all palliative care without 7.5 hours. But if such a doctor is there, tomorrow, if I am the patient, as he sees me, in spite of his PPE, he may still say, I am going to look after you. I see you are in pain. I see you are breathless. I am going to look after you. Just that one sentence conveying to me that somebody cares. That's so important, isn't it? Otherwise, you have these masked and capped creatures walking around, looking only at screens and images, and you are lost. It starts there. Today, till that curriculum does get implemented, the doctor has not been taught really what safe of dose of paracetamol at what frequency is really safe. Simple things like that. And how to treat my breathlessness. And they were worried actually by Friday. Okay, I see that we would need these medicines. We would need low dose morphine. How do we get it? It's not there in our hospitals. They're already thinking about that. We are working with them to try to make that available. There is a solution. COVID crisis is with us. We need those short courses and we need them now.
Yes, agreed.
Good, Dr. Rajgopal. You are saying that even one sentence from a doctor treating a COVID infected, saying that I am here to care for you, can make a lot of difference for a person who is sitting or lying in isolation, amid people under coverall with these sealed masks, and it's a scary images, and that's the reason the whole fear has started setting in the society. Dr. Rajni, when it comes to providing this kind of comfort to the patients, and also Dr. Reddy said that if in any family somebody has had an episode of some serious healthcare problem and has been in a hospital, would have got some kind of understanding about palliative care. How much do you see it in your day-to-day work? Do you really see that the patients are sensitized about that, or their families are sensitized about that?
So, I think sometimes it becomes a little difficult for me to answer these questions because I have been practicing this kind of care for years and years now. So most of my patients' families are sensitized to asking for palliative care and comfort. That comes from the fact that the patient knows what their rights are, that I deserve comfort at all times. My pain needs to be addressed in totality. Dr. Rajgopal taught a lot of us who have been mentored by him that palliative care is about addressing total pain, and pain is not just physical pain, it's mental pain, it's your spiritual pain, it's all kinds of pain. Now if I don't try to address, I have patients as a lung specialist, I have patients who have chronic lung diseases where they are going to be breathless for 5 to 8 years of their life. If I do not address their suffering, I have a sense of failure. And the patient never gets relieved of their suffering. And you also have another person there, the caregiver, the family member. So when we work with sensitizing, we work with sensitizing the entire ecosystem here. The patient knows this is what they need. The doctor knows this is what is their duty to provide. The caregiver knows that, one, I am able to provide this for my family member, and they also feel supported by the doctor. So you build an entire ecosystem like that. I'm going to say that there are small oases in our country, in many, many places which are doing this. But as Dr. Rajgopal mentioned again, growing from 1% to 2% is not enough for a country of this magnitude. I would also like to say one thing. Simple measures, like when you said that I'm here to take care of you. When I am this person in a mask and a PPE, this is not something new to lung specialists. We go in masks and full things like this when we have patients with MDR tuberculosis or patients who need reverse isolation. For example, they are immunocompromised. I need to watch out that I'm protecting them from anything I might carry. A simple thing like carrying a name tag and a photograph of mine. They can only see my eyes, but if they see my eyes smile and express comfort, there is connection there. That person is not alone. One of the hospitalist physicians at Cornell, Dr. Laura Colby, she's an internal medicine hospitalist physician. She wrote this really beautiful article, which was there in the Washington Post sometime in April. And we know that New York has had about, I think, 390,000 deaths, so we're almost double of, in one state, double of what's there in India, 20,000 plus deaths, 390,000 cases and more. So it's a crisis of a magnitude where you will never have enough palliative care physicians. And she wrote this article which says every doctor has to be a palliative care physician. The specialist palliative care physicians are for the really complicated cases, but each of us needs to find that palliative care physician within us. That's the only way forward. We have to teach these concepts in schools. It has in our medical schools. It has started. There is a beginning, and I'm hopeful. But at some level, it will be wonderful if the patient community, the entire community, asks for it, saying, "I want this. This is the support I need." And where the course that Dr. Rajgopal mentioned, I will tell you that I attended the entire course. I have completed my Palli-COVID certification too. And it's really amazing because it teaches each and every doctor those little nuances. I might know all about my medical field, but these little nuances which can comfort a patient, that's what I learned in that course. So I think there is a lot of possibility here for changing the entire environment. This is a horrible crisis. We have to look at what it exposes in our system to try and build on all those things that we can. We can improve the system. This is the opportunity I see here.
That's wonderful, doctor, that you are practicing it for very long and you have done all possible augmentation to make it even effective for patients. Dr. Dhamija, all patients may not need palliative care at hospitals. And despite our doctors and healthcare professionals becoming sensitive towards it, trained for it, it may not solve the problem. What's your opinion about our families, practicing palliative care and what need to be done there? Because that's one very important area where palliative care has to be practiced. I think it has to start from families as well.
You're absolutely right. Actually, we faced this challenge initially when this pandemic started. So what we did was we started our telemedicine OPD, Monday, Wednesday, Friday from 1 to 2, 1 hour, 3 times a day. And we tried to, start virtual family meetings because this lockdown period, no one was, able to visit the families or the families coming to the one-to-one face-to-face meeting with us. So what we started was the virtual family meetings, and that has been going on for last 2 months now. And it has been fairly successful. Not that I would have loved to do it, but at a larger context, but it's still a beginning. And every day we have about 2 to 3 such virtual family meeting in that 1 hour session with my 2 faculty members, calling them and then discussing their issues, whether it is symptom control or it is psychosocial counseling or psychological support or social support. So that's what, but there are issues in that also. In spite of legalizing telemedicine in March by the Medical Council of India, we still cannot prescribe opioids through the telemedicine prescription. There is a 3 classes of 3 lists of medicines which you can prescribe on a tele prescription, which a patient can take to the chemist or pharmacy and get those medicines. And those class of medicine which we require for our palliative care management, they are all, they're not allowed to prescribe. So that challenge still remains, and I'm sure that this kind of webinar would help us to convince the concerned authorities in Medical Council of India to look into it and find out the solution for that. So in addition to those challenges, we still have a number of other challenges, whether it is in outpatient or inpatient COVID positives or inpatient COVID negatives. And of course, as Professor Reddy said, the non-COVID patients, which we call elephant in the room, because they are the ones who are being neglected because of this all COVID. So all these patients, particularly if I say in neurology, so we are not getting stroke patients coming in window time to be thrombolized. We have hardly had 2 or 3 patients in last 2 months which could make it to the window time of 4.5 hours to our hospital so that they could be treated with clot busting drugs. So that is one impact of the other side of this COVID pandemic on non-COVID patients. Similarly, I'm sure people with heart attacks and people with other chronic conditions, non-communicable diseases are facing the same problem. So coming back to COVID and palliative care, so what we have seen in our own experience, little bit experience, which we're trying to make it, it's not very robust as the Kerala palliative system is, but still we're trying to, start it in our own humble way after my association with Professor Rajgopal and Smriti Rana in last few months, and almost couple of meetings in Kochi and one in Ahmedabad by Dr. Roop Gulshanani. So what we have done is we have augmented our telehealth service. That's what I told you. And the second is we're trying to prevent hospitalization of these patients. What we require through telemedicine, we try to make their life comfortable so that they don't have to come to the hospital for small things. Those patients who are inpatient but are COVID positives and require palliative care, they are facing a lot of problems because most of the system is now geared up for the COVID patients, other ones, and all the clinicians are busy and overworked actually looking after those patients who are mild to moderate or maybe critical, depending upon the stage at which they are admitted. So these COVID positive patients who require, as I said right from the beginning, from the triage to the ICU, we are also facing challenges in those patients that we are not able to provide them as good as we should have. But still, we are making a beginning, and these patients are being provided whatever we can. So those patients who are COVID negative, but in the hospital, being suspected zone or the other chronic illnesses, they are also having a lot of being stigmatized, lot of being, these patients having. Our aim is not to, have these patients infected. So spread of infection is one very important issue for these patients, and then social support and the psychological supports and the guilt factor. So we are all addressing these issues, and these are one of the challenges we are facing in our hospital.
Thank you. You made an important point for those patients who may need certain kind of medicines which can be prescribed to them through telemedicine medium, which people are using. But at the same time, there are a good chunk of important medication, critical medicines are out of it. What is the how this particular problem of those who require important critical medications, and also those who are seeing some of the emergency situations like stroke, heart attack, and are not going to the hospital, and obviously it has to be taken by their families, by their the neighbors. And when they are not reporting to the hospital, that means something is lacking in the society or the families. And then that the whole question of compassion and being sensitive towards somebody who is suffering, I think is being taken over by the fear. Dr. Reddy, again, I would like to understand from you that this kind of operational issues like, not including some kind of medications or medicines in your telemedicine framework, can these things be quickly addressed by the government and policymakers, or is there any certain challenge included in that which we don't know, and we may be looking at from a very layman perspective, something more is there to deal with?
Well, basically, there's always been certain degree of hesitation in having drugs which are considered to be a little narcotic or narcotic related. I mean, morphine related drugs have always been under some degree of suspicion that this might lead to widespread misuse, incorrect prescriptions, addictions, and so on. But I think we can regulate many of these. I mean, we allow alcohol to be sold as the first priority item after lockdown is eased, but we do not allow morphine to be given to people in severe pain. That's a bit of a contradiction in society. So we ought to be able to deal with some of these issues in a much more intelligent and humane manner. Having said that, I think there is a need for making this demand loud and clear. Otherwise, the powers that be and the regulators do not really understand the need for this. So there has to be a demand built up for this, not only by the people who need the interventions and their families, but also supported by the larger health community. Unless the medical community stands up and says, this is a part of treatment, this is necessary, and this needs to be provided as a part of essential service, that's important. The second element, of course, is, let us say there is somebody in home isolation, and their relatives are also put on quarantine. Who goes and gets the medicines? Now, there, of course, the question is whether the medical shop will supply on some sort of a prescription. That's a different issue. But again, it's important to engage community volunteers. It is seen in Kerala, for example, or even in Andhra to some extent, that participation of community volunteers along with the primary healthcare teams has really made a difference even in COVID, in contact tracing, in providing support to those people who are in home isolation. So I think what we need is also a people-partnered public health, and including palliative care. So unless we actually broaden this movement, firstly, the demand will not get built up, the demand will not get amplified through the medical community, and secondly, the supply chains will not function actively. So I think we need all of these to happen.
Well, good, doctor. Ladies and gentlemen, we had 52 minutes of our discussion going on, and we are getting a lot of questions also from the viewers. So I would just like to bring in some of the questions and at this point of time. And some of them are very interesting. A question which I'm going to read out is an important from the point of view of challenges being faced by the healthcare professionals while we think about them to provide palliative care. Being a frontline worker in this COVID times, we face a lot of issues during conversation and counseling of the patient, their relatives, due to multiple layer of masks, face shield, and we have to shout, speak aloud to explain their very critical situation. The whole purpose of palliative care dies there. What can be done regarding this? Dr. Dhamija, you are on ground zero. How to deal with this problem?
So there is no alternative to the universal health precautions. So we have to have these precautions for the sake of our own fraternity, frontline health workers, as well as for the patients. So one of the alternative is to engage in a known COVID areas where in a dedicated areas where you have a little bit flexibility in terms of not using PPE but using mask and the other like goggles and masks. So we have tried to make use of those known COVID areas in the hospital where PPE is not the one where I usually work, not as a PPE person, but as a normal mask and normal goggles. So that's what is there. And second is, of course, the telehealth. There has to be an element of trust building when you talk on a virtual platform. So these are the challenges which we have faced and try to overcome with time.
There's another question which highlights a very different scenario, and which I think also creates another need for palliative care, and this time is for the healthcare workforce itself. The question is the lack of workforce causing burnout in the overburdened current workforce to depersonalize the care they provide? So I think what the question is being asked about is that the overload of this COVID disease on the healthcare workforce, and especially those who are working on ground zero on our COVID hospitals frontline. Who is taking care of their mental health? Aren't they facing the challenge and fear of life every day, day in, day out? And have we created any kind of support system for these people from whom we expect to practice compassion for others? How compassionate we are for them? And I will go take this question. There's an interesting aspect. I'll look a response from Dr. Rajgopal as well as Dr. Reddy. So, Dr. Rajgopal, what do you think about it?
Absolutely, Kamal. Like these people who are going to care for me tomorrow are critical. They are so critical, and they are not only not supported, often stigmatized and even attacked, and that can be very demoralizing. Unfortunately, the crisis came on too fast, but it has been there for 2.5 months. We should have support systems for them. Absolutely. The person goes home tired and should have somebody to whom they can talk ask a few questions when that person is quarantined. Yes, support systems can be made, can be created, they can be electronic, they can be safe enough, and they are absolutely necessary.
Interesting to you. So there is a support system, possibility of creating a support system. But Dr. Reddy, there is one thing is to create a support system. The other thing is to remove the support system. We are seeing people, doctors being, their stuff being thrown away by their landlords, nurses being chased away. And that was my positioning line when we started this discussion. How much there is a need from the government or the public health authorities to address this problem, and not always by maybe penalizing the people, but making more sensitized towards this issue by reducing this whole fear narration around COVID-19.
Well, there is an absolute need to ensure that there is no fear that translates into stigma and harassment. And I think we are partly responsible for it, and the media too, for having made this epidemic appear such a killer epidemic that everybody in the community started feeling that the moment a healthcare provider approaches them, they're going to catch the virus and drop dead. So I think that has to be, conversation has to be changed. It is not a Vaishik Mahamari that we should be talking about. We should be talking about a bimari, and it's an illness. And that is something which also we must emphasize, that very few people die of it. I think the public mindset has to be changed first. Secondly, we have to communicate with clarity and firmness that these are the people who are not only saving lives now, they are the people you will have to depend upon when somebody in your family falls ill, when your wife has to deliver a child, when your father has to be looked after for a heart attack, or your mother's diabetes needs to be controlled. The moment you start rejecting them, you're rejecting healthcare for yourself and your own loved ones. So that also has to be a very clear-cut message that has to go forth. Therefore, both some sense of enlightened attitude as well as even self-interest that we need the health system functioning, we need these health workers functioning, is important for the community to register. Coming back to the earlier question, how can people in PPEs communicate empathy? Well, certainly I believe even with the PPEs and masks, we can communicate empathy. After all, when you hear Lata Mangeshkar or Muhammad Rafi singing a song on a radio, you don't see them, but from the voice modulation, you make out how wonderfully well they can actually empathize with you or create a resonance in you. So every doctor has to learn even how to use their voice as an empathetic instrument while communicating with the patient. And pediatricians do it particularly well when they talk to children.
Very interesting, Dr. Reddy. And this is, something I think the PPE is not an impediment to when you want to convey compassion to your patients. Your hand at the back of a patient, whether it is under gloves, will convey the same kind of empathy to them. We have completed our 1 hour of discussion, and here we kind of come to the end of our first session. But unlike our physical conferences where the stage need to be emptied for others to occupy, the good part of online conferences is that people can continue with their discussion. So while I go forward to the next set of speakers, I would be very happy if whomsoever can continue with us on that session also, and we can take their inputs as well. There are also a lot of questions coming from the Facebook, and we will try to deal some of them in the later part of session. And I'll request Dr. Rajni if she can continue, because she wanted to share some of the experiences of how to support healthcare workers. So with this, we come to the end of how we are going to bring in this component of palliative care to sustainably manage COVID-19. And what we heard from our experts today, that whether it is pandemic or an ailment, palliative care is the most essential part of the response which we need to give as a society, as a healthcare system. So the one aspect which need to be dealt with by the healthcare system or the public health decision makers is to ensure that we have a quick capability enhancement when it comes to our healthcare workforce providing palliative care to the patients infected or affected by the COVID-19. And I would also like to take this a key message coming from Dr. Reddy, that let's not always create or enhance the fear around COVID-19 by saying it Vaishvik Mahamari. It may be a pandemic as per the WHO, terminology. But more than Mahamari, what we need to understand that this is an opportunity collectively becoming to us as humanity, that we deal with this with the most best possible compassion, empathy, and care for all. With this, we go forward to our next set of speakers and the next discussion, which is about the impact of those deeply affected and not infected. And for all our audience, it is important to know that COVID-19 has affected all of us, each one of us. From, it's not about only those who are at a higher risk of infection. Even the children at home, they are affected. Their life has completely changed in last 3 months. The playground, which was their favorite place, is no more there for them to access. This too might have added a lot of psychological burden on them. And in a country like ours, which has not, everyone having that great space to live in, people may be having a sense of confinement during these times. How we are going to deal with them, how we are going to provide care for them as well. So let's go to our next session, and I would like to introduce our speakers here. We have Dr. Smriti Rana, Director Program, Pallium, India. We have Dr. Roop Gurshani, Consultant Neurologist and Epileptologist, PD Hinduja National Hospital, and also a member of ELICIT, End of Care in India Task Force. We have Bhavna Isar, Founder and CEO of Caregiver Sathi, and we have Dr. Samira Jahagirdar, Assistant Professor, Department of Critical Care Medicine, Mahatma Gandhi Medical College and Research Institute, Pondicherry, or what we call it as Puducherry today. Continuing with us is Dr. M.R. Rajgopal, Founder and Chairman, Pallium India. And we also have from our previous session, Dr. Rajni, Dr. Dhamija, and I can also see that Dr. Reddy has kindly continued with us. So we may come back with some question to him as well. So thank you so much, everyone, for your time today to discuss about, palliative care in a scenario of COVID-19, which has affected all, infected a few. Let me go to Smriti Rana first. She is the one who is, implementing many projects related to palliative care. Dr. Rana, in the context of COVID-19 and also in the context of universal health coverage as defined by WHO, what do you believe that how this palliative care can be provided for everyone who is affected with this, not infected? What is your opinion on it?
Thank you, Kamal. Well, listening to all my colleagues speaking in the hour before, they've covered a lot of really relevant points. First up, I'd like to say that, the pervasive myth about palliative care largely has been that it is reserved for people with terminal illnesses and only for pain management. But in reality, palliative care looks to address and alleviate all serious health-related suffering. And I think what COVID is showing us is how intrinsically a person is connected to his or her community and to the whole social fabric. So you talked about universal health coverage, and Dr. Dhamija talked about the fact that palliative care is prescribed as one of the essential principles, apart from promotive, preventive, curative, rehabilitative. And I'd just like to put it through the lens of what we're talking about today, the infected and the affected. If a person is not infected by COVID, there is still this sense of foreboding, this anxiety, this uncertainty, and the lockdown, which in itself is a response to COVID, has brought with it a whole bunch of other stressors that most of us have never experienced, and loss of livelihood, poverty, all of those things. So there's a huge component of suffering that has come as a result of that. People who are infected and recovering, they still have a huge, the physical component, the emotional component, the social and the spiritual again. And people who are critically sick and in advanced stages, you also have grief, anticipatory grief, you have bereavement, you have the trauma. So the thing about palliative care is that it has always looked beyond the person, beyond the disease to the person, and always functioned at all these different domains. So we are uniquely placed to pivot and contextualize our response to any one of these domains. And end-of-life care forms only a small part of that response. Rajni talked about difficult conversations having to be had, delicate conversations. That is part and parcel of palliative care training. We are taught how to have difficult conversations in emotionally distraught times. There is, of course, the physical distress symptom and symptom control and all of that. But we also look at the person in the context of where he or she exists in society or culturally. And so I think palliative care becomes very relevant in that context. And I also want to make a special mention of the fact that there is a collective sense of grief and trauma that we're experiencing as society. You talked about some sort of empathy deficit, but I think there's also a lot of grief apart from the fear. And I don't think there's any other discipline that is as intimately acquainted with grief and mortality as palliative care is. And, trauma is not just a response to an acute event. A prolonged exposure to a non-normative experience also causes trauma. And what we're experiencing now is not normal, no matter what we call it. We say the new normal, but it's really not. We're all having to constantly adapt to it. And so many of you have made the point, and I'm sure people in the audience have as well, that there is a vicarious suffering of the healthcare worker, watching this happen in front of them. And the trauma that they are going through. So many of our colleagues who've spoken with us from other countries and where they've been in the trenches, in COVID-19 ERs, have told us how traumatized they were by witnessing what they did. So palliative care has a toolkit that can customize itself to different kinds of suffering. And I think from that point of view, it forms quite a beautiful bridge to universal health coverage along all domains. So, yeah.
Good. So you have expanded the horizon of palliative care substantially. And in the last conversation, we were primarily discussing about in the context of COVID-19. And when we talk about COVID-19, invariably you start relating it with those who are unfortunate enough to die because of COVID-19, and how they are spending those last moments. But as you said, that palliative care is not related to just COVID-19, or it might have created a higher demand or a higher requirement of this. So when it comes to palliative care needed for, let's say, a larger section of society, with people from marginalized segment to people suffering from chronic diseases to people living in isolation, and there is isolation of a different kind also. We see a lot of, our elderly living in almost isolation in this country. So when it comes to this whole spectrum of people who require palliative care, how much the delivery of it has got impacted during COVID-19, because this is again a major, uh, you know, uh, factor which is changing the way things have been happening in our country. So I'll go to, for this Bhavna sir. And Bhavna, how do you see this getting impacted in terms of palliative care? And since you work for the community, what is your, observation so far?
So, I think Smriti has set a very nice foundation, and I'd like to build on what she has said and what the previous speakers have said. One, to the idea of what palliative care is, and two, what COVID or this pandemic has brought up for us. The first thing is that this pandemic has brought out the best and the worst in such amazing proportions. We have discovered our ability for innovation, we have discovered our ability for compassion, we have discovered our ability to reach out in such incredible ways, in as much as we have discovered our dark side as well. So I think it is quite an inflection point or a moment of reckoning, so to speak. But that on one side, my understanding of palliative care, and I'm a non-medico who works at the intersection of palliative care with supporting family caregivers. I believe the key tenets of palliative care are that it goes beyond the disease, like Smriti said, which is that it takes all the stakeholders into account. That's point one. Point two, it looks for that which is invisible, that aspect of pain or suffering that is not evident, but we need to tune into it, listen to it, and be able to address it, whether it is with the patient or whether it is in that setting. And I think the third thing is that it calls for compassion, not just for the patient, but for the affected, for the person who is treating. So there is a huge element of compassion that palliative care calls for. And finally, I think it is moving away from being an expert to a sense of a partnership. So the healer, in as much as healing, is also feeling healed in the partnership. And I think these tenets are absolutely essential. And today's time calls for that. And that's why I'd say that I'm building on what Smriti is saying, which is that palliative care has the tools or the method to bridge for what is required. And I believe that it is time. The other thing is that palliative care rests on a multidisciplinary nature. It says that it's a cross-functional team that goes and works with the patient and the family and so on. I think it may be time that healthcare or health and care in the way that it has been practiced for a few years now needs a multidisciplinary approach where we can bring in more facets of stuff that has happened in other places. For example, if we had a bunch of engineers, I know that some techno geeks will get totally excited about this problem that we just highlighted, right? How do I convey a voice in a soft, empathetic way through my PPE? I know that there are some engineers who will like jump at it and be able to offer three or four or five solutions. That's possible today. We can use technology to be able to not just reach a large number of people, but offer innovative new solutions, if only we have the ability to be multidisciplinary in our approach. The other thing that I believe is that, just referring to my note, is that there's a contradiction in healthcare and education. I belong to a family of teachers. My mother has been a teacher for many years, and her thing has always been, I will be a successful teacher if I have made myself redundant. And I think a doctor will be a successful doctor if a doctor is not really required. It is in contradiction with industry. If healthcare becomes industry is you have to keep the patient coming back. You have to keep the patient ill and ailing. There is a need for education and healthcare to be such that people who administer it become redundant over a period of time. However, if it is seen like an industry, then we need to keep people as customers. So there's a contradiction there. So we have to relook at how we are offering healthcare. In the spirit of what Dr. Reddy said, it is a partnership, public and volunteer partnership, so that it can be universal healthcare. And I do think that bringing in family caregivers is absolutely essential, because family caregivers tend to be invisible for a variety of reasons. Family is expected to be caregivers. We have a cultural tradition. Good sons and good daughters and good wives are caregivers. Um, Second, 60 to 80% of caregivers are women. Caregiving is a gendered role. And third, the mental health of a caregiver is absolutely essential to the healing and sometimes cure of the patient. But the caregiver is invisible to everybody. For the reasons that it is embedded in the family, it's most likely a woman, and it is the mental health of this person. So it is a complex problem of multiple layers that we need to change in our society and how healthcare is looked at.
Thank you, Bhavna. So another important point coming in from that, family need to be part of the whole process of caregiving when it comes to palliative care. There is another aspect of palliative care which we have, discussed as well, that is not the only aspect, but that's one of the major aspects. At a time when we know that this is going to end, and that's where the end of life palliative care is also equally important. And in this, the role of family becomes even more important, and the need of those difficult conversations, which many of you have highlighted that need to be done, becomes even more important. Let me take Dr. Roof here, and since he is working strongly and for long in this area of care life, and also is a part of this task force elicit, Dr. Roof, what is, as per you, for end of life care, how much families need to be engaged in that, or how much we are engaging with them and preparing them for this loss and helping in reducing their grief, or so that it is not coming as just a jolt one day to them? How much of it is being practiced, especially in the area where you are operating?
Thank you, Kamal, for that question. I would like to imagine that things are getting better, but I'm not so sure. One of the things that we wish would happen is that death should actually be normalized. It should be a part of normal conversation over the dinner table, while you're talking about routine things, that people should not look on it as something that is upshakun, that if you talk about it, you bring it upon yourself. Nothing of the kind. Because the more we push it away, the more it becomes scarier and scarier. You have to actually normalize it. It has to become a part, something that you can actually discuss laughingly also. And when you do this, then it becomes a part of natural conversation, and then it becomes easier for doctors and patients to recognize this reality that is there, well, for everybody at some stage in their life. Because we have realized that, and this is something that, an insight that comes from palliative care, that is that for most people, a good death has a huge emotional component. And that emotional component is about, it's called life review. It's like, uh, like settling your emotional accounts, asking for forgiveness, giving forgiveness, saying, I said this, you said that, finishing off all of those things. It's like a bahi khata of life. And we've realized that unless people go through that, they do not really think that they are that they can pass on comfortably. Now, all of this can only happen when this conversation is easy, and it can only happen when doctors are able to inform patients that now is the time to get on these conversations. So it's a wider conversation that not just I wouldn't say doctors and patients. I think India as a whole needs to have with itself. This is maybe in something as bad as this, maybe there is something good that will come out, and that we will now begin to talk about this more openly.
Smriti said that there is a toolkit for palliative care. Is there a toolkit for end of life care as well, and especially for the families who are facing a possible loss of life in their family? And how do you help the family, kind of prepare for that?
Yes. So ideally, you break this kind of this whole counseling into three elements. One is the first is advanced care planning, living wills. Now we all know of the living will. The living will is a document, but the document actually has two parts. It has you have to select somebody who will speak for you when you are not able to speak for yourself. Because at the end, most of us will not be able to speak for ourselves. And the other is your wishes for when you are very ill, towards the end of life. What do you want? What do you not want? Who do you want around you? Where do you want to pass your last days? At home or in hospital? Whatever. So the first element is, we call this whole thing advanced care planning. I mean, most of us are aware of the living will. The term that came after that was the Advanced Medical Directive, which was the document that put these elements together. But now we look on it as advanced care planning, that you discuss all of this. Now you need, ideally, you should have somebody who can counsel you through this. Okay. But since at this moment, we have hardly anybody in that category. If anybody is really interested, there's something called the Conversation Project. It's a website. I mean, you can look it up, but there are many more. And experienced doctors can actually also help, though we believe that this is a special skill by itself. Then, of course, the other issue that comes up that people require help with is, you can call it caregivers, and even, well, I would put it as spiritual caregiving. And again, there you need, again, ideally, I mean, in our society, especially amongst Hindus, we don't have a clergy which has the responsibility of doing this, unlike, for instance, Catholics. You can, I mean, if a Catholic person is affected, then one of the first things that happens is that the priest uh, speaks about why this is happening. Because people always have these existentialist questions कि मुझे क्यों, ये बीमारी मुझे क्यों हुई, इनको क्यों हुई, हमारे को क्यों हो रही है. So all of those discussions, and then taking the patient and the family, the patient and the caregiver will have what is termed anticipatory grief. कि ये तो अब आ ही रहा है. And then after it is done, then the family has to take care of their own sense of bereavement. Now, all of this is I wouldn't say that there is a simple one single toolkit, but yes, if we had an ecosystem, I mean, ecosystem is not as simple as a toolkit, but if we started to build this ecosystem, we would be a long way ahead to being able to tackle it all. I'm sorry, it's not a simple answer to a.
No, thank you. So, most of the questions which we are facing don't have simple answers. So, let me go to, Dr. Samira. We have talked about many of the aspects related to, many of the target group for palliative care, but there is one target group which is quite, kind of marginalized and ignored. Dr. Samira, you yourself come from that one target group, our LGBTQI community. What is palliative care need for them? What they are suffering from in general days or times, or especially at a time when COVID-19 had hit us, hard and have disrupted almost most of the things which were normal before this pandemic.
Yeah, sure. Thank you for this opportunity. So as we say that whenever I start talking, I just take a brief introduction. What is that LGBTIQ? It's an acronym for lesbian, gay, bisexual, transgender, intersex, and queer or questioning people around. So in that spectrum of rainbow, I fall into the T category. I'm a transgender person. I identified as a transgender person and started my gender transition when I was 32 years of age. Currently, I'm 43. So, as I said, what we were trying to discuss here is what impact this community had. And to be specific towards, yes, all the components had at their own impacts, but what major impact transgender community had. Let me give you some examples about it, how and what way it started up. Yes, almost everybody is knowing about it, that transgender community in this spectrum is the most marginalized community. The transphobia, fear about transgenders, fear about homosexuals, that phobia perpetuates and leads to stigma and discrimination. And that is what the impact got created almost double, triple when the lockdown period started. News came somewhere in March that some of the groups of Hijra groups were in one of the South Indian city got stigmatized, where the posters were being put up all over the city that Corona inke wajah se hota hai. Corona gets spread because of people like this. Okay. So already there is a stigma that Hijra community is ये तो HIV और AIDS वाले लोग हैं, अभी तो ये कोरोना वाले लोग भी हो गए. So unknowingly, just blatantly, the transphobia, the phobic attitude gets converted into deep core and brutal stigma. This is not a one-time event, or it is something which has just peaked. It is just an iceberg. There was quite a lot of things going underneath that, and it was going on since days, years, and months. And what we are seeing is just the tip what has happened, and as an opportunity being taken by those antisocial element or transphobic elements in that particular city to stigmatize this particular community. There were also some incidences where we were talking about, Bhavana was talking about, the family and the role of family and how important the family is to take care of people. Okay, but it is absolutely a paradox in when you talk about people from LGBTIQ community. Family is a threat for people when especially these families are transphobic or homophobic. Unfortunately, those who came out to their parents and they told and got locked down under one roof, they were being pushed that how you can be this way, why you cannot help yourself to build up this way. Their stress level was so much. And we had a recent example that unfortunately one of the community member, we lost it. There are other issues also related to that particular individual too. So at the same time, you cannot reach out. Okay, because of lockdown period, there is no opportunity available to come out, go physically meet with the people, discuss, talk, or run off and get away from that particular environment which is damaging you. You cannot convey to the legal authority, the police, because the traditional thinking is that the family is supposed to protect you, and you are a woman, you are in love with a woman, you cannot run out, you are not eligible to take that decision. Best people to take care of you as being a woman is not someone else but your father and mother. This is absolutely a total paradox, what we came across and what is being coming across. Yes, we had some amount of community strategies build up and helped out to few people around and fooled police people and created support. If it would have been some shelter group available or social groups available where these people would have held up and would have been taken care of, it would have been really a great help for the community. We talked about, Bhavana also talked about empathy. Bhavana also talked about going beyond the disease. This community is tormented with mental health issues. Specifically transgender community, the statistics of suicidal rate and committing suicide is as high as 50%. It is 50% higher than any community, the society at large. So can you imagine how much amount of the stress this has impacted on the community? And slowly we'll come to know more and more amount of news in media that how much amount of suppression of this particular part has been happened up. We do not know how many of them, they have lost their lives and they are morbidly ill at this moment. Smriti was talking about essential health care. When we talked about hormones, when we talked about few essential medications, we talked about telemedicine and incorporating important drugs and educating healthcare professionals that these drugs or medications also should be prescribed. I had a friend from Kerala who called me who was about to get prescribed her medication. The next week, the lockdown started and the hospitals got shut down. The endocrinologist doesn't know that whether I can prescribe endocrine therapy for her. The same situation happened with two other transgender people around who contacted me. Now, what answer I can have? The medical professionals just shut down and their gender dysphoria, gender incongruence just shooted up. There was so much amount of mental health imbalance this community faced during this particular situation. Unfortunately, hormones, the male hormones and female hormones are not considered as essential medications. But for transgender clients, it is something which is really essential. You'll see that they will commit suicide. I had personally myself a tiny experience that my hormones got over, and me being a doctor, I could not procure from my pharmacy, did not have that particular brand. I could not get it. I simply did not had a vehicle. I could not go from this city, my hospital where I'm staying, to the city which is 15 kilometers away. I just got locked down. So much amount of suffering, mental torture, I had it up because of this balancing work, hormonal effects going on, and at the same time managing each and every corner of my particular life. I'm privileged. I could get some help. I could explain to it. I could show the letter and travel and get it up. But what about people who could not get it? Definitely it was a problem. The same essential things happened about anti-tubercular drugs and antiretroviral drugs. Many of the part of this community who are HIV positive, they did not get the medications, very important medication, the retroviral medications for them. So there was a huge amount of gap for them. Dr. Roop talked about end-of-life care. I'll touch upon even that particular, the paradox which is involved for that. We talked about, Dr. Roop talked about advance directive, who should be there with that particular person next to him or her when he or she is dying. Will some doctor acknowledge that I have a partner, I do not fit into the marriage bracket, okay, which is not existent? Will somebody acknowledge that, will allow me? Will that have a legal boundary to that? How many of them are educated about it? That is what is absolutely, that my wishes may not be respected. My wishes may not get carried at that particular moment. How many of us know about it? How a most marginalized transgender community in India is Hijra community. How many of us we know that how a Hijra dies? What are their rituals? Where they get buried? What happened to them? What discrimination happened to them when they conduct their rituals in the middle of the night, where nobody should take part in that, nobody should see that, no sound should come on that. Now what kind of the society is that you do not allow even the last right of that particular individual to undergo? Now put it into the bracket and think, each and every one of us, you think that what kind of a palliative care, the in-depth and the core amount of palliative care needs this community will have it.
Thanks, Samira. You have touched upon almost every aspects of what this transgender as well as the whole LGBTQ community is facing. Dr. Raj, what is the institutional solution available for such kind of problem, which has multi dimensions to it? There is a whole need of mental health care support. There is a need of critical care support. There are many things which may not be considered essential for normal, what we call normal society. So there is a very peculiar need of a certain community, and they are part of our society. We, or every healthcare system, is responsible to this community as importantly as for anyone. So what do you feel, what is the solution available for that?
Interestingly, Kamal, you use the word institutionalization. The institutional policies, etc., are the easiest. They're not there now. They are the easiest. The most difficult part is the social attitude, of which I am a part, you see. Every component, human component of the medical system, the minister, the policymakers, the doctors, the nurses, the hospital cleaners, we are all part of this community, and we have not been taught how to provide equitable care. We provide equal care. I sit in this institution. If you need care, come to me. I'll give it to you equally. And if you cannot get to me, if you cannot get access, sorry, tough luck. You die in whatever fashion you do. This is true for LGBTQI. It is true for elders living alone. Do you realize how they really live and how they die? It is true for geographically isolated people. And it is true for many culturally discriminated against people, including people with HIV, even today. So, what am I saying? I am sure that adoption of policies by the healthcare system, which has to be mandatory for every institution, every healthcare delivery place, should have this component of providing equitable care to vulnerable population, including LGBTQI. But for that to happen, for that to be effective, Kamal, you are most important, because you have strength of reaching out to the people. And our lack of awareness, Samira will testify to the fact that doctors and nurses and all have very poor awareness of LGBTQI and their issues. We are not taught. But even if we are, the awareness of the community that sexual orientation is something to be respected, and that stigma can be removed, just as earlier Roop mentioned about death being an enemy, LGBTQI people being enemies, and that has to change from the attitude, public attitude. And there, what you are doing now is so precious. I'm so glad you introduced Samira into this group, and her voice has to be heard loud and clear.
Thank you so much, Dr. Raj. So, two things. There is we need to create institutional change, but more than institutional, there has to be the social support framework. And when it comes to the social, let me go to Bhavna. And since you work in society, in communities, what solution, Bhavna, you feel is there for a problem which Samira is facing, or people like Samira is facing? She has said that she is the privileged one. She is a persistent professor. She is a doctor herself. But what about many such who are living with without these privileges, without being noticed or without being heard?
Yeah. Kamal, I wish I had a nice solution or a nice recipe to offer. I can just about say that I have, a few things to offer which we could explore. We could start from that point. I think I am so grateful to have heard Samira, because it helps me see a part of the world that I had so far not seen. So I will refer to the piece that I spoke about earlier, which is tools or a way of looking at things in palliative care gives you the ability to be able to see that which may have been invisible so far, one, and two, have the patience and the compassion to deal with it in a sensitive way. I think that some of the conversations that Dr. Roop alluded to, which should be normalized, are conversations like death. I do think that it probably in my grandmother's generation, it was a lot easy to have a conversation about death and say, I want to die like this, and so on and so forth. Somewhere along the way, we have lost those conversations. And we need to go back to some of those conversations. I also think that difficult conversations, which was also spoken about, which is there is grief, there is loss. We are anticipating grief death is likely to come. It may not come in 2 or 3 months, it may come in 2 or 3 years, or that it is very difficult to look after somebody with life limitations of any kind, are conversations to be had. I also think that it is important to normalize something called compassion fatigue. We put compassion on a pedestal. We say that, doctors are angels and gods, and I have huge respect for doctors, but I have to say that we dehumanize them when we put them on this pedestal. Doctors are human beings. They have all kinds of feelings. They struggle with guilt and helplessness and inadequacy and everything human. And we have to have ways of being sensitive to the human who is a doctor as well. So we have to normalize them and not make them into gods. That's unfair, I believe. I also feel that both family caregivers and doctors have something called compassion fatigue, and we need to have systems in which we can replenish ourselves. Family members who are caregivers are burdened by the pressure of our stories. We grow up on stories of Shravan Kumar and Savitri and whoever else, who are like these incredible gold standards. I mean, Savitri brought her husband back from the dead. Shravan Kumar died for his parents. And these are difficult standards to attain. And caregivers need to be human so that they can say that they do the best. And the measure of what they do is not that they fought death, but I think it has to change from not fighting death, but living well. It does not matter whether the life was few months, few days, or many years, but that you lived it well was important. So I do think that expecting that doctors will have all the answers is also a highly, it's like putting them in a spot. And to the point that Dr. Rajgopal referred to, which is, I think that, there needs to be an ecosystem in which many people from many disciplines are holding hands so that we can change the social narrative around caregivers and caregiving. You see, whether they are family caregivers and they are under this pressure that they must do everything, they must spend a lot of money, fight, leave no stone unturned so that they can look after their family member, leads them to do things like, the things that Dr. Roop spoke about, which is put people on, not consider their wishes, for example. Because what will I be thought of if I didn't do everything that was required for my father, for example. So we need to change how caregivers are seen, how sensitively we look at them. And caregivers are not just family caregivers. Caregivers are also our doctors and healthcare providers and social workers who work in the areas of grief, death, and dying. This could be the first few steps. I don't know how this will unfold. I wish I had a better...
Thank you so much, Bhavna. You actually made some good points, but more importantly, you have also brought back our attention towards the mental health, to the well-being, to the support system for healthcare workers, our doctors, our nurses. And for that, Dr. Rajni actually wanted to share some of her experiences, and that what are the measures being used for supporting these healthcare workers. I think that's the right time to hear Dr. Rajni, since you have highlighted this point, that how we can support our healthcare workers and start treating them in a better manner, or maybe in a more human way.
I have to say thank you to Bhavna and Dr. Rajgopal for setting the stage for they've set a whole lot of, they've set the background for what I would like to discuss. We spoke about the fact that we are all part of this society. Bhavna spoke about the fact that Doctors should not be put on a pedestal. They are human with human emotions, human vulnerabilities. And when we talk about mental health, we spoke about the mental health needs of so many different kinds of patients, so many different patient communities, many different vulnerable populations and caregivers. What about the mental health of healthcare workers? You mentioned burnout, and Bhavna mentioned compassion fatigue. Burnout is an epidemic amongst healthcare workers, which is completely not spoken about. When we talk about anything like in the West, maybe burnout is acknowledged. We know that 70% of physicians and more than 50 to 60% of nurses will eventually encounter burnout in their lifetime, in their practice. In India, the only population it's been measured in is among psychiatrists. I think the Bombay Psychiatrist Group is the only one which thought to look at burnout in mental health professionals. But when I speak to my younger colleagues, they tell me, ma'am, I'm not burnt out. I'm charred to ashes already. Now that's a 32-year-old who's got his entire career ahead of him. And it breaks my heart because we can't talk about mental health amongst doctors. We are supposed to be on that pedestal. If I have a fracture, my patient is going to tell me, "Acha, mujhe nahi malum tha ki doctor ko bhi problem hote hain." Well, I felt I'm made of the same flesh and bone. So I can have a fracture and the doctors can talk about their diabetes. We can talk about our fractures. We can brag about our heart disease too, about how much stress we go through. But we can't talk about what affects our mental health. And this particular crisis during COVID has been one of not just regular burnout and compassion fatigue, but this is moral distress. This is moral injury. So when we look at the spectrum of injury, some people, there's a lot of discussion about the terminology burnout or compassion fatigue. So what Bhavna also mentioned the best and worst of society coming out. So I'd like to mention some of the good things that have come out. We talked about healthcare workers being turned away by landlords. We've also seen community groups come and deliver care packages to resident doctors of the municipal hospitals in Bombay and in Delhi. We know about measures taken by mental health non-profits and establishments which are offering support. Think of the stigma for a resident doctor to approach their own hospital psychiatry department saying, I'm having an anxiety attack. Their worry is going to be, will they lose their position? Will I lose my PG seat? Will I miss a term? So when you have non-profits and other organizations offering mental health support for these young and vulnerable and actually so full of promise young professionals, that's very essential. There have been people who are doing conversations like, stars meet heroes, which is wonderful. You have, TV and Bollywood stars who are striking up conversations with resident doctors in COVID hospitals who are cooped up in either their hostels or their hotel accommodations just to lighten them up after a long shift. The amount of trauma these young people are seeing every day, these young nurses and doctors, the amount of trauma they are seeing across the world. We are going to have a pandemic of burnout and we need to address it. The entire society, if you know a healthcare worker, just reach out with support in any form for them. A music piece, offer food to them, just send them a hug online.
That's wonderful message, Dr. Rajni, that the whole society need to ensure that our healthcare workers are not getting burned out or getting that compassion fatigue. Because we are just left with maybe 6 minutes of our discussion. So I'll request all of you to be a little brief so that we can cover a couple of more important aspects. And one such aspect is, Dr. Roop is about DNAR, at a time, we have, it will be incomplete to talk, if we could close our discussion about palliative care without talking this important aspect. What is the psychological burden you see when there is a need for practicing DNAR, and how much of it is possible in country like India, where getting this kind of nod from the family, or for example, as Dr. Samira said, that we don't know sometimes that who is the family of that patient. So how difficult it is to practice this aspect? Can you put a brief light on that, so that we can complete this.
Okay. So DNAR is, first of all, I mean, I'm not sure if everybody is aware what CPR is. CPR is cardiopulmonary resuscitation. So when the heart stops and then the breathing stops, you have to, all doctors are supposed to rescue the patient by trying our best to restart the heart and the lungs. And this means pumping the heart, pumping the chest, if need be, putting in a tube, putting the respirator on, and so on. Now, the thing is that if it happens to somebody at the end of a long life, then there is just a 1 to 2% chance that this will work. On the contrary, you are doing this to a 80-year-old person, all that you will do is you'll break their rib cage, their bones, and finally maybe the heart will start for a short period of time, but the brain is damaged. So all that will happen is that instead of going peacefully, that person will, whatever little time they have left will be tortured. Okay. So the important thing is that most of these situations are predictable. Because these are predictable, doctors should speak to the patient if possible, if the patient is in a position to undertake this conversation, or whoever is speaking for the patient. And here I'll just add a small bit to what Samira mentioned. The AIMS, All India Institute End of Life policy document, which is up right now, actually accepts partners, life partners, not necessarily married, as equal to spouse. So it's actually there. That's first government document that actually does that. Anyway, coming back to somebody who's at the end of life and the heart is going to stop. The point is the doctor has to be able to open this conversation up. And families have to be able to accept this conversation. Patient, families, everybody. So there is a wider space that all of us have to be prepared for this conversation. But the actual conversation between doctor and patient also has to be done. Now that takes something very special that it's actually not really special. It is but it is something that palliative care gives us as a standard skill, and that is communication skills. How do you make this conversation happen? You will be surprised. I have learned this now at the age of, well, I'm 61 now. So I learned it barely about 2 or 3 years ago. So you think about it. I mean, you would think, as a layperson, you would think that I should have learned it when I was finishing my MBBS. No, now.
Thank you so much, Doctor. So quickly, let me put it in the context of COVID-19. Dr. Dhamija, you are seeing patients being treated for COVID-19, and you are also must be seeing that people dying of COVID-19. Has there been an opportunity or a need of practicing DNAR in any of your patients, and how difficult it was to do?
Thank you, Kamal, for taking.
And I would request a brief answer, sir. We have just 3 minutes left.
Okay. So I'll just take 30 seconds because I wanted to bring this. We have not been possible because of the cultural and social barriers in this pandemic. So DNR, which is being now talked about, and ICMR has given the guidelines, it's not being still put into standard practice of care in most of the Indian hospitals, including mine. I want to touch upon another parallel pandemic which we were talking about amongst the healthcare workers and getting infections and being socially, being outcasted or being stigmatized. And this has been happening in Delhi a lot, and I don't know about the other cities. In my hospital also, we have faced these problems, having residents being, turned away and being not able to go back to their homes with little children. So we have made a changes. We are making a change. Society is accepting now, but still we have miles to go. The other thing which probably Smriti also wanted to touch upon was the social isolation and the marginalized group, particularly in elderly, where we don't have much of a community support, or the system is not that robust to help them out. So we need to reach out to them to make them socially cohesive rather than being socially isolated. So that's what I wanted to convey. Thank you very much for having me.
Thank you, Dr. Dhamija. So here we come at 5 p.m. We have completed 2 hours of our discussion. It was wonderful, talking to all of you. We saw a lot of questions coming in. Before we close, today's discussion, but I promise you the discussion, the conversation around palliative care should continue. And I'm sure it will continue post this webinar also. It is not supposed to be limited in one webinar. Dr. Rajgopal, your quick closing remark. What is the way forward for palliative care? What is your vision? What we want to achieve? How this society will be proudly saying that we care for our people, we care for our patients, we care for our doctors.
The vision for palliative care is really the vision for healthcare. To quote an ICMR document, the doctor's duty is to mitigate suffering. He quotes what Dr. Srinath Reddy said. It is to cure sometimes, relieve often, and comfort always. And the ICMR adds, there is no exception to this rule. Healthcare has a responsibility to mitigate suffering. When you look at diseases, look at MRI scans, when you forget the human being, instead of providing healthcare, we may end up doing assault and battery on the person, jumping on the chest and breaking ribs. Healthcare providers' primary duty of care is to mitigate suffering, and integration of palliative care to healthcare will help us to achieve that. Thank you.
Thank you so much, sir. It is brief but very impactful message. So our audience, here we come to the end of our discussion, which we started by saying that we are seeing the best and the worst of human nature during this COVID-19. And the most important thing, what we want to achieve is that everyone come together collectively to care for each other when it comes to fighting like pandemic, which is unprecedented for human history, which is creating damage, which is unforeseen, which is taking toll not only on lives, but on relations, but on mental health, but on every aspect of human life. So with this remark, we close this conversation today, but with a promise that IHW Council will continue its campaign and its support and its work towards creating palliative care, a discussion which need to include every one of our society. This program was supported by Pallium India as their public interest initiative, and we thank them for their kind support. Our audience can also send their questions through WhatsApp. We are thankful that they were watching today and they sent their question. We tried to answer as many as possible. But if there are more questions, they can send those through WhatsApp. They can go to our FB page and send their question. We will try to address these questions one-on-one or through some next webinar. Please continue following our page to stay updated with the latest information and support in terms of taking care of your health, your well-being. Till then, eat healthy, sleep better, think well, and stay safe by following personal hygiene and physical distancing. And while doing so, do try to help those who need additional support, both physically or in mental support to cope up with this pandemic. Thank you so much for watching our session today. Thank you.
Thank you.
Thank you.